Thank you very much, Ankarin. And I hope, over the next half an hour, I'm able to have the same passion that the previous speaker had. He had amazing passion, along with Ankarin. I think it's a neurology thing that you're able to demonstrate all your passion on stage. Thank you to the organizers once again for inviting me, and thank you for those who've managed to stay on till the end. Now, my task today is really to talk about the range of clinical trials that have occurred over the past year that are likely or could potentially impact on your clinical practice in the future, and currently, sorry, not in the future. Now, what I'm going to be talking about is mainly concentrating on antiretroviral trials. I'm restricting to phase 3 and 4 and relevance to this region, so the Asia Pacific, and if it's not, then really at least conferring some significant global impact. And I'm trying to cover both HIV prevention and treatment, so you can appreciate it's a very large area. And because I've had the liberty to attend a lot of conferences, particularly last year, try and include a range from all those conferences last year, including ID Week, which is not mentioned there. So you've heard this from Chen Xiong. I think, this is the biggest trial of the year and is really essentially a game changer. And I think some people have heard this term used again and again, but it has really shaped the world of HIV prevention tremendously. So Chen Xiong really described this, but this is the purpose one, and you now can't talk about the purpose one without talking about the purpose two. Purpose one was a study which involved mainly cisgender women, not on PrEP and eligible for not being HIV tested in the past 3 months, and they were randomized to one of 3 different arms, either subcut lenacapavir every 26 weeks, TAF-FTC oral daily, or TDF-FTC daily. And because it was a placebo-controlled trial, each arm had a companion placebo arm, whether it was an injectable or oral medication. And the trials has essentially already been published in the New England Journal of Medicine, and I ask you to refer to the paper, which was published in July of 2024. Now, the primary endpoint was lenacapavir incidence, HIV incidence in lenacapavir versus what was described as a background HIV incidence, and this is the incidence that you would expect without the use of PrEP that would have been expected in a placebo group. It's unethical at the moment to use placebo controlled trials in PrEP studies. And Purpose 2 is very similar study design, but this is within gay and bisexual men who have sex with men, transgender women, transgender men, and gender non-binary persons. Also not on PrEP and having been recently tested for not being HIV tested in the past 3 months, this time 2 arms, subcut lenacapavir versus TDF-FTC. Right. And looking at the baseline characteristics and the differences between the 2 trials, Purpose 1, very young population, median age of about 21, predominantly Black women, and high rates of chlamydia core infections, up to 25%. So you're recruiting the right kind of population. Purpose 2, slightly older population of a median age of 28, and a very gender diverse population, up to 23%, and made up of non-white race in 66%, and Hispanic and Latino ethnicity. Sites where Purpose 1 and Purpose 2 were collected, and just to highlight that Thailand contributed about 12% of the overall population to Purpose 2. And you've seen this before. Purpose 1 prevented 100% HIV infections in those receiving lenacapavir, and in Purpose 2, 2 HIV infections in participants receiving lenacapavir. So very high efficacy. In Purpose 1, the median follow-up was 44 weeks, and in Purpose 2, median follow-up was 39.4 weeks. And the primary efficacy endpoint was comparing the incidence rate ratio in lenacapavir and TAF-FTC versus background HIV incidence in Purpose 1. Lenacapavir prevented 100% infections. TAF-FTC, not much different from background HIV incidence. You can see the incidence rate ratio there, 0.84, confidence intervals cross 1, so it's not too dissimilar to background HIV incidence. In Purpose 2, lenacapavir prevented 96% of infections compared to background HIV incidence. Secondary analysis where they compared it to TDF-FTC, TAF not too dissimilar to TDF-FTC, lenacapavir 100%, preventing HIV infections in that group, receiving lenacapavir. Comparatively, in Purpose 2, lenacapavir prevented 89% infections compared to TDF-FTC. And this is why we need an injectable PrEP, and where a lot of advocacy needs to drive this. Now, this is, of course, data from Purpose 1, and it's reporting adherence in TAF, FTC, and TDF, FTC in 10% of the cohort. But what you see as the graph moves to the right, and the darker graphs, or the bluish gray section denotes the percentage of participants with high adherence as delineated by more than 4 doses per week. And what you can clearly see as you move from week 8 to week 52 on the left-hand side in TAF FTC arm, starting with 40% high adherence, as you move towards week 52, it's only 11% at week 50, starting at 48% at week 8 to 11% at week 52. And it's similarly across TDF-FTC. In fact, TDF-FTC, the percentage of those who are adhering to high doses is less, and it gets worse as you go along. So there's something particularly within this population where adherence is an issue to oral based PrEP formulations, particularly in sub-Saharan Africa. Lenacapavir adherence was high comparatively, and injections were on time. 91% at week 26 and 94% at week 52. And of course, you have, this was repeatedly, you could see it in social media. This was a game changer. Science magazine named lenacapavir for PrEP as its scientific breakthrough of the year. You had a standing ovation in the AIDS conference, which is not often the case. So it's always very, very good to be a part of that. And very useful resource information. The Body Pro nominated as one of the top 10, or as the top 10 HIV clinical development of 2024. And as it should, it deserves this place. It has revolutionized HIV prevention. But of course, the problem is going to be excess. And we don't want history necessarily to repeat itself with what's happened in this region and globally as well in terms of delayed access to oral and now injectable treatment. It's very hard to get excited about these drugs, particularly for countries like Malaysia, where following the release of the conference data, 120 countries were named in terms of being able to get generic versions of lenacapavir. And unfortunately, Malaysia suffers, where I'm from, suffers from that. I always call it the curse of the middle-income country, neither here nor there. And as a result, you suffer more than low-middle-income countries in terms of access to newer drugs. Now, moving themes a bit along to long-acting antiretroviral therapy, there are two essentially pivotal trials, which I felt shaped long-acting antiretroviral therapy from this year. And I think Sheng Xiong may or may not have mentioned it, but they were firstly with the CARE study. And the research question here was essentially, can you implement long-acting cabotegravir and rilpivirine in low-middle income settings, in this case, sub-Saharan Africa, using a public health approach? So essentially using viral load monitoring every 6 months and with no baseline genotype, which is essentially what is being done across low-middle income settings. So multi-site randomized control trials, sub-Saharan African sites, they had to be virally suppressed before being randomized and were either on 2 NRTIs in dolutegravir or 2 NRTIs in an NRTI. And they needed to have no history of treatment failure, randomized to either long-acting cabotegravir or rilpivirine every 8 weeks or continue oral antiretroviral therapy. And very simply denoted here, but just highlighting the baseline characteristics, 58% female, 99% Black, 1/5 had a BMI of greater than 30. And these, in the past, has been looking at ad hoc analysis of Atlas and FLAIR trials, showed that this was one of the risk factors associated with failure to long-acting cabotegravir and rilpivirine, as was a subtype A1, and this provided additional information on that, 57% subtype A1 in a population which had a lot of NNRTI exposure, and with that concerns around using using rilpivirine. And on further archived proviral DNA testing, 10% at baseline had high to intermediate to high rilpivirine resistance, and 8% intermediate to high cabotegravir resistance. Similar virological suppression rates across both arms, essentially non-inferior. Treatment satisfaction scores essentially improved upon switching to long-acting cabotegravir and rilpivirine, which was unsurprising, and the discussion around whether A1 and BMI, A1 subtype and other factors such as BMI appeared to be of a less concerning risk factor for virological failure in this study. The other question that has been consistently addressed with long-acting cabotegravir and rilpivirine was whether you could use it in patients with poor adherence. And in reality, and I know in some parts of the world, this is being done anyways, but you did not have any data to back it up. So this was really addressing that question because majority of the indications of starting long-acting cabotegravir and rilpivirine is that you had to be virally suppressed on your previous regimen before switching to a long-acting antiretroviral regimen. So looking at a particular population who had barriers to adherence, as defined by poor viral response to oral antiretroviral therapy of more than 6 months and loss to follow up with antiretroviral therapy non-adherence of more than 6 months and having no resistance to either of the regimens. Before they were randomized, they had a step that they had to go through, which was to intensify the oral continue the oral antiretroviral regimen, and were given economic incentives to encourage viral suppression. And in order to progress to the next step, they had to have a viral load of less than 200 copies per mil. So not really reflective of the population that we really wanted. So in step 2, they were randomized to long-acting cabotegravir and rilpivirine for every month instead of 2 months, and continue oral antiretroviral therapy. And having said that, despite attempts at a requirement for having to have a viral load of less than 200 copies per mil, 17% in each arm had a baseline of viral load of greater than 200 copies per mil. In terms of the outcomes, the primary outcome, did not show any difference in terms of statistical significance, but it was significant in terms of the secondary outcomes of virological failure and treatment failure, where the injectable arm performed better. In fact, there was superior efficacy in the long-acting cabotegravir and rilpivirine arm in the secondary endpoints as mentioned there. And this has been reflected in guidelines, and so it's always nice to see when you have data and they shape guidelines, in this case fairly quickly. So this is from the IS-USA guidelines. So in patients with viremia, consider cabotegravir and rilpivirine in those who are unable to take antiretroviral therapy consistently after exhausting all supportive efforts, where there's high risk of HIV disease progression, so you have very little choice otherwise, and the virus remains susceptible to cabotegravir and rilpivirine. But you do need to follow up the patient intensively and support them with very case management services. Now, looking at treatment-naive studies, and we really had to pick one, and this was from HIV Glasgow this year. And the research question here was, a lot of us have been around the region have been using dolutegravir, lamivudine as first-line therapy, not as first-line therapy, as a treatment switch in patients virally suppressed and want to simplify their regimen further, or have developed comorbidities, including problems with kidney function. So the question here was, and a lot of guidelines in high-income settings recommend this 2-drug regimen in treatment-naive patient populations, but make the exception that they're not permissive in patients with CD4 counts of less than 200 or with a viral load of greater than 500,000. So in an attempt to answer this research gap, patients with CD4 counts of they recruited patients with CD4 counts of less than 200, viral loads of greater than 1,000 with no upper limit. And they had to be hepatitis B negative, and they were randomized to either the dual therapy arm of dolutegravir and limivudine or the triple therapy arm of TDF, FTC, and dolutegravir, and followed up for a period of 48 weeks. The numbers weren't huge, but 150 to the dual therapy arm and 77 in the triple therapy arm. And just looking at the baseline characteristics, 30%, 32% had viral loads of greater than 500,000. So really looking and homing it at this population with advanced HIV disease with a median CD4 count of about 120. And in the intent to treat exposed population, very little difference in viral suppression rates between the two arms. And when you then look back and analyze it according to the different viral load thresholds, and the numbers get lower as the viral load thresholds go up. So for example, in more than 500,000, you're looking at numbers of 53, more than 1,023, but you get a sense that you can see that essentially in the dolutegravir, the dual therapy arm performs non-inferiorly, or if not even slightly, there's a suggestion that performs even slightly better than the tree therapy arm as the viral thresholds go up. The rates of virological non-response were similar across both arms. And for those who developed virological failure and they were able to amplify the virus, there were no resistance to either NRTI or INSTI in either component. And so what this adds is it adds that at least a greater degree of confidence of using dual Dovato or the equivalent in patients with CD4 counts of less than 200 and higher viral load thresholds. Now, second line art, I'm going to spend a bit more time on this, and the reason why this I feel is particularly important is because it has greater relevance to our region, and also it was performed by a group of investigators across this region. And I'm probably going to home in on just the DEF study and the VICEN study. These are studies of treatment-experienced patients with NRTI resistance. And essentially, along with Geske's study, which was presented in AIDS 2024, they provided, so they're not novel studies, but they provided extra evidence supporting the recycling of nucleosides, in particular TDF and 3TC, when they're combined with a higher genetic barrier drug, such as dolutegravir or bictegravir, in either achieving in treatment naive or maintaining in treatment experienced patients, irrespective of the baseline NRTI resistance, which WHO hasn't made a formal recommendation yet, but it's being reflected in other guidelines. And it confirms, once again, the very, very high genetic barrier resistance to dolutegravir and bictegravir, and adds further information to earlier data provided by the NADIA and the 2SD studies. The DEF study, I think you've heard it a couple of times as well throughout this conference, looking at patients who failed an NNRTI-based regimen and who had no previous exposure to PIs or INSTIs, led by the Kirby Institute, phase 3-4 trial, and basically were randomized to either the standard of care, which was 2 NRTIs and darunavir-ritonavir once daily, or an NRTI-sparing arm, which was darunavir-ritonavir and dolutegravir. Because of increasing data from not just the region, but globally as well, of the efficacy and safety of recycled TDF 3TC and dolutegravir, a third arm was then subsequently added as a comparator arm to the previous 2 arms. Baseline characteristics, just want to highlight that we had 25% Asians within this group, so significant attempts at recruiting from patients within this region. Sorry. Oops. And essentially, sorry, beg your pardon. I apologize. This doesn't want. No, sorry. So essentially and then I'll probably go quickly through this, the dolutegravir arms, and this is at week 96 follow-up, the 48-week data has already been published, essentially showed that there were both dolutegravir arms, so dolutegravir combined with darunavir, and the TDF, the recycled TDF FTC and dolutegravir were both superior to the standard of care arm of 2 NRTIs and darunavir. So they not only crossed the non-inferiority thresholds, but were superior as well, and therefore supporting current WHO guidelines of using dolutegravir, preferably in second-line ART regimens. And we are in a field where we have become very weight obsessed, and this is reported as an outcome in most clinical trials. Once again, weight increasing as we move to week 96. But not only that, both dolutegravir arms were associated with greater weight gain than the standard of care darunavir and 2 NRTIs are. The Vicen study, important study only because we have long-term follow-up data. And this is 144-week follow-up data. And I just wanted to home into the viremic arm of this study. Very similar patient population, TDF, FTC, Favrance, failing an NNRTI-based regimen, randomized to two different arms. Arm B is the viremic arm, as defined by a viral load of greater than 100. And the question here is, do dolutegravir-based regimens outperform PI-based regimens, which was the standard of care at the time? And does it matter whether you use TDF-FTC in the dolutegravir arm or TAF-FTC? Does it make a difference? Just wanted to highlight, this was a population with a very high baseline NRTI resistance of up to 92% and with 64% overall TDF resistance. Particularly in the dolutegravir arm, 56% had no TDF activity. So high baseline NRTI resistance. And if you look at viral load suppression up to week 144, which is very useful data, within the dolutegravir arm, so the red and green at week 144, they more or less converge. So, whether you combine with TAF, FTC or TDF3-TTC, it doesn't really matter. And you can certainly see that they outperform PI-based regimens. And it's important to know this because some doctors within the region still have this reluctance of switching patients from PI-based regimens to dolutegravir regimens in second line. And it's data like this is very useful to present to doctors across the region. And using a lower viral load threshold, similar rates of you see a trend which is very similar, but of course with lower rates of viral load suppression because you're using a lower viral threshold. And in patients who are on dolutegravir-based regimens, and this is almost unusual, because this is up to week 144, within the TDF3-TC dolutegravir, you only had 3 patients who had a viral load of greater than 1,000 copies per mil. Within the TAF-FTC dolutegravir arm, 7. So collectively 10, compared to 31 patients in the PI-based arm. So more patients who had virological failures in the PI-based arm compared to the dolutegravir arm, but no resistance mutations to dolutegravir in those who had confirmed viral load rebound, which is unusual. We had high levels of resistance in those failing first line, those on dolutegravir in the Nadia studies, as well as in the DEF study. And so this reinforces once again the use of dolutegravir in second-line regimens, and it provides that very important long-term outcome data. There was another study, and I just go very briefly around this, and this was looking at the question around whether patients who are suppressed, so this is not failure, but suppressed patients on boosted PI regimens, whether it was safe to switch them to a TAF-FTC bictegravir, so integrase inhibitor-based regimen, or continue the boosted PI. This was known as the GESCUR study, and it was in Haiti. 48-week follow-up, there was no difference between the two arms. So if you switch to integrase-based inhibitor regimen, or if you stayed on a PI-based regimen, it did not matter. So once again, reinforcing across the region, so for patients on PI-based regimen, we have overwhelming data, this combined with S2D2 data, that we should be switching our patients from a PI-based regimen to dolutegravir. This is happening, I know, but in some cases, in some hospitals, and in settings including mine, there has been some reluctance of that to happen. And this is how data can reinforce that. And this is now also coming and appearing in guidelines as well. This is from ISUSA guidelines. 2 minutes on PrEP, and this is event-driven PrEP in women. This was largely a symposium from CROI 2024, talking about how we generally, within the HIV prevention community, are more doing an injustice to women by not offering them event-driven PrEP. And it was aptly titled, "Do Vaginas Demand Perfect Adherence?" Now, this is looking at a pooled analysis across 11 demonstration projects, looking at the HIV incidence among women on oral TDF FTC with adherence data. So 2,955 women, cisgender women. And of course, if you take 7 tablets per week, you're going to have no HIV. 4 to 7 tablets per week, 1 out of 658. With a risk reduction of about 90 there, the HIV incidence per 100 years is 0.13. And when you compare this, the PrEP effectiveness related to the adherence is actually not too dissimilar to men who have sex with men. So this is becoming more supportive of women taking this 4 pills per week in women. Not conclusively, but it provides that greater evidence supporting that. Coupled with favorable pharmacodynamic and PK data, which I won't go through because it'll take a bit long, but this is now being reflected across guidelines, how women now, and this is from BASH and the BIVA guidelines, they now recommend that if HIV acquisition to receptive vaginal sex happens, you can start with a double dose, 2 pills, 2 to 24 hours before risk, similar to men, so should not be dependent on gender. However, you cannot just continue taking 2 pills 24 and 48 hours after and then stop. You need to take a single pill for 7 days thereafter and stop. And this is known as the on-demand PrEP for women, the 2 to 7, as opposed to the conventional on-demand PrEP for men. And it's reflected in the PrEP guidelines in the UK as a draft consultation, not ready for press, but it's already in the EACTS guidelines. And that's some PK data which you can refer to, and as well as I think, editorial within the New England Journal led by Linda Gill Becker around this topic. Finally, very quickly, I'm going to end with weight and some of the confusion, once again, around doctors, clinicians who are obsessed about weight related to antiretrovirals. And this just added more confusion to the whole weight narrative related to integrase inhibitors or TAF. This was called the Paso Doble study from Spain, randomized open label phase 4. And the question that they were asking is that if patients will virally suppress on a regimen without any history of treatment failure, and they were not on an integrase, if you switch them to a 2-drug regimen without TAF or a TAF-based regimen with bictegravir, was there more weight gain associated with TAF? Which has not been shown in other studies, having said that. Baseline characteristics are looking at important, particularly when you see outcomes which don't quite match what you expect. And just homing, this was a patient with a CD4 count, mean CD4 count of 712, but more importantly, looking at the pre-treatment switch regimen, because we know that TDF is weight suppressive, and so is efavirenz. And when you're switching from weight suppressive agents, sometimes to a weight neutral drug, sometimes the weight neutral drug can be blamed for the weight gain, when in actual fact it's because you're switching from a weight suppressing drug. So 30% from TDF in both arms and 50% in efavirenz. Virological efficacy, unsurprising, dolutegravir 3TC, non-inferior to bictegravir TEF FTC. So nothing surprising there. But what was surprising was that there was certainly weight gain in the TAF FTC bictegravir arm. And this is important for countries even who don't have TDF, because TAF eventually will come your way. So there's a difference of about 1 kilogram in weight there between the 2 arms at week 48, which was significant. But when you talk about weight, it's always important to home out the percentage of patients with weight gain of greater than 5%, and 20% in dolutegravir lamivudine arm, and TAF FTC 30%, so clinically significant. And looking at the pre-treatment NRTI switch, more so in the those who switch from tenofovir and those who switch from abacavir. So adding to this confusion even more. And I add, and it's always great to debate this, but certainly has added more confusion around the narrative around weight gain, because this was rather surprising. Now I see Ankarin standing up, so I'm presuming I'm way over time, but I just want to conclude. 2024 has been an exciting year for HIV prevention, certainly with the lenacapavir study, as it should be. Long-acting cabotegravir rilpivirine can be implemented in low-middle-income settings using a public health approach. We have a wealth of data from studies, including those conducted from low-middle-income settings, to confirm what we know already, which is the superiority of dolutegravir-based regimens above PI-based regimens, and that should be reflected in our clinical practice after those who have failed on NNRTI-based regimens. I think the PrEP guidelines in women and the evolving guidelines around that pertaining to event-based PrEP is very exciting. So watch that space, because it's becoming more permissive. And the PASO Doble study adds more confusion to our ever-changing weight gain narrative around TAF. And with that, I'd like to thank you. And I'm sure my colleague has highlighted this. We're holding 2 workshops in March. So we have in February. One is a tropical medicine workshop, which is affiliated with the University of Glasgow, and that's on the 22nd of February 2025, and also a HIV ST update 2025, and that is on 8th of February of next month. So please, we're open to international participants, so sign up, please, if you're interested. And with that, thank you, and I apologize if I'm over time.